Thank you so much. So I just want to say thank you all for attending this. I'm very glad to be here. I'm a neuropsychologist. I'm a clinical neuropsychologist and also work in research spaces. Um, I do want to say that this topic was very broad, and so there's absolutely no way I can do justice to it in an hour, but I'm gonna try. So bear with me. Um, so I do have a couple. Oops, are my slides advancing? There we go. Okay. I will also say I can't see the chat as I'm presenting. So if anything comes up, if you want to ask a
Yeah,
question or jump in, please do that on the mic. I won't see any messages that come through.
that's okay.
So,
I can cover them at the end of presentation too.
oh,
So
okay, thank you. So I do want to state any disclosures that I have up front. I do receive funding from a COBRA grant that is funded by NIGMS. As I mentioned, as I was introduced, I'm currently the co-director of our clinical core there. I've also received support in the past from an R01 grant where Dr. Jessica Caldwell was the PI. I'm the PI of a foundation grant where we're looking at remote cognitive monitoring in cohorts receiving intervention for Alzheimer's disease. And then I've also in the past received support from the Women's Alzheimer's movement. And so I just want to be upfront about the different support mechanisms that have helped me along the way. And then I did use AI in the creation of some graphics, but not in the creation of any data. The data and the sort of graphs and such that you'll see are all taken directly from journal articles and peer-reviewed research. All right, so I have two broad learning objectives for today. One is to understand sex-specific dementia risk factors particularly as they pertain to women, given the topic of the talk today. And then to recognize the importance and role of modifiable risk factors. And I think this segues very nicely from the prior talk as well as one of the later talks today, which is going to focus on that behavior modification piece. All right. So I want to start with with how we're going to use a few different terms. And just so that we're all on the same page. I recognize it might be a little bit basic and repetitive, but I wanted to make sure that we're all on the same page when we're using these terms. So when we talk about dementia, it's an umbrella term for significant cognitive impairment. Um, Cognitive impairment such that is severe enough to impair daily functioning. Um, it can look, if you've seen one person with dementia, you've seen one person with dementia. Dementia can present in many different forms and can have a variety of clinical presentations. It can also be due to a variety of different underlying pathologies. So Alzheimer's disease is one type of pathology that results in a dementia. But dementia is the syndrome and sort of the quantification or qualification of the extent of cognitive impairment. Other types of dementia, and again, keeping in mind the audience that I'm speaking to, I'm not going to delve into this too much, but vascular dementia, dementia with Lewy bodies, frontotemporal dementias, etc. And so the reason I bring this up is because the literature on dementia prevention, um, it's often a little bit difficult to sort of call it dementia prevention because very often the research is conducted on disease-specific cohorts. It's conducted in cohorts who either have Alzheimer's disease or are at risk for Alzheimer's disease. It's conducted in, Parkinson's disease cohorts, but they're disease-specific cohorts. So dementia prevention or dementia is sort of an overarching term. And so I just want to say up front that a lot of the research and the data that I'll be presenting today centers around Alzheimer's disease, just to sort of streamline it and keep it cohesive. Um, I'm glad that the game was played before this, otherwise I would have given away one of the answers. But mild cognitive impairment is that stage. It's more than normal aging. There are cognitive concerns or complaints either from the patient themselves or someone who knows them, who sees them on a relatively frequent basis. Um, and then you can find sort of evidence. It's not just self-report. You can find evidence, objective evidence of that cognitive impairment, whether that is, and I would be remiss if I didn't put a plug in here for neuropsych testing, whether that's on objective neuropsych testing, whether that is um, in other areas. Sometimes it's you know, I would say neuropsych testing is the gold standard to diagnose that mild cognitive impairment. But sometimes it may be fairly obvious on other screeners and such. Um, in mild cognitive impairment, and this is really the crux of how it differs from dementia, is there's no impairment in daily functioning due to that cognitive impairment. So someone with a Parkinson's disease, for example, may have mild cognitive impairment, and because of their tremor, they may have some limitations in their daily functioning. They may need some help with things like dressing, buttoning, clothes, etc. As long as it's not due to the cognitive impairment, we're not crossing over into dementia territory. Again, similar to dementia, the term is etiology agnostic. What I mean by that is, again, it's sort of it's a characterization of the syndrome as opposed to the underlying disease process. And then continuing to discuss some terminology that we'll use. Given that this talk is focused on women, I think it's important to delineate what we refer to as sex and what is referred to as gender. So sex is a biological construct. It is based on chromosomes, gonads, hormones, etc. It is a biological construct. Gender is a societal construct. It encompasses behaviors, expressions, access to education in some circumstances, access to driving, access to healthcare. And so when a determination, and I use the word determination very intentionally, when someone makes a determination of what the person in front of them identifies as, that is based on gender, that is based on how they present. When we talk to each other in social situations, we're not looking at chromosomes, we're not looking at gonads, we're not looking at each other's hormones. So we're looking at gender. Whereas, and I think this is relevant because when we look at sex-specific factors, they're called sex-specific risk factors, for example. But I would encourage everyone to look at, well, how was that determined? Is it, people checking off on a form, I'm a man, I'm a woman, I'm a trans man, I'm a trans woman, or is it something that is determined from, looking at someone's chromosomes or gonads or hormones? And the reason I bring this up is because it impacts how research comes to its conclusions. It impacts how we think about the different risk factors. It impacts what conclusions we make and how we advise the patient in front of us. So I would just keep that in mind. We're not going to make this sort of a central focus of the talk today, but I do want to just put this out there that when we're looking at research studies that talk about sex-specific factors, when we're looking at research studies that talk about gender differences, how was that actually determined and how might that impact the conclusions? All right. So now to move on so I'm done with the definitions, I promise. So now to move on to the sort of meat and potatoes of my talk. I do want to sort of orient you to how we'll be doing this. The first part is talking a little bit about sort of orienting you to some of the sex differences that exist in both the clinical presentation as well as the genetics and such behind, specifically for Alzheimer's disease mainly. Like I said, a lot of the research has been done in that space, rather than the more umbrella term of dementia. And so we're gonna talk a little bit about what those differences look like up front, and then move into the sociocultural lifestyle modification piece. And the focus of my talk, because I looked at the topics that other folks are going to be covering today, the focus of my talk is really sort of parsing apart those differences, those sex differences, to look at, well, how does this inform the care that we provide? How does this inform how we recruit in our research studies? How does this inform the recommendations that we make to patients and their families? And then, so I say this because this talk may raise more questions than provide answers. I apologize for that in advance, but unfortunately, some of the answers just aren't available to us at this point in time. So my hope today is that by the end of this talk, those questions will become part of routine clinical practice. All right, so 2 out of 3 folks who have Alzheimer's disease are women. That's a significant majority of people who have Alzheimer's disease are women. Women are 1.5 times more likely to develop Alzheimer's disease. And then the interesting fact is, 60% of caregivers today are women. 60% of caregivers, specifically to those with Alzheimer's disease, are women. We know that caregiver stress, it takes an immense toll on the individual. And we also know that chronic stress is a significant risk factor, that it increases risk of developing later life cognitive decline, including Alzheimer's disease dementia. And so we're already looking at people who are not only more likely to develop the disease, but we're also looking at people who are in the specific environmental sort of position of not only caring for those with Alzheimer's disease, but also then having that chronic stress increase their risk. Some genetic components have a stronger impact on women. So, for example, we'll talk a little bit about the ApoE4 allele that we've all read about and seen a lot about in the research today. But it tends to differentially impact women more than men. And I have some data on that coming up. Coupled with this, so not only are we talking about the current impact and the current state of things and the current numbers, but when we think about how women are represented in research and in clinical trials, there's often underrepresentation. It was in I want to say the 1990s or the early 2000s, when the NIH required that studies include women. Prior to that, most research was done on male rats because female rats were considered to be too complicated. Because female rats were considered to, the menstrual cycle, the hormones were considered to be a bug, not a feature, so to speak. And it was hugely problematic because we were conducting all these studies from animal models to human models. We were conducting all this research where 50% of the population was underrepresented. And we were applying conclusions and findings that were exclusively based on men or male rats or male primates. And we were applying them to females. And that was hugely problematic. So only, like I said, in the last couple of decades was there a requirement for women in human studies and female animal models to be incorporated. And now we're at the point where there's a lot, there's women or females in the samples But the explicit exploration of those sex differences, explicitly looking for how did these two groups of men and women, male rats and female rats, how did they perform differently or how did they look different? That remains underexplored. If you think of the last, few papers that you've read, I hope that you will find that more and more are including a detailed analysis and a breakdown by sex, not just saying we had 50% women, but actually looking at whether the conclusions and the results are different for men and women, are different for male rats and female rats. Um, And so this continues to be a problem. And when you look at some of this data that you have here, I'm going to first draw your attention to the top, that panel A on the top left. So this is taken from a study that came out in 2020, and came out this year. It was a population-based longitudinal analysis using data from the ERIC study. And it includes over 12,000 people. And the follow-up duration was just over 2.5 decades. It was 26 point something years. And if you look at those lines where you look at women on the left, men on the right, don't worry about what test really you're looking at or what each of the individual lines are. But if you just look at the group of lines, you're looking at women who perform better than men on average. And yet, when we look at, and I'm a neuropsychologist, I'm going to harp on the cognitive piece for a little bit, bear with me, okay? But women tend to outperform men on some cognitive measures. However, a lot of the reference groups that we use don't differentiate between women and men, and I'm going to come back to that in a little bit. I want you to look at that bottom panel B there, the incident rate of dementia. And it's separated out by men and women. And you see there that in the 45 to 54 age range, you've got some consistency in men and women. They're not vastly different. But look at that 55 to 64. So these, can you see my arrow? If I'm moving it around? No? Okay.
Oh, wait,
So
try again. Try again.
here we go. Can you see it?
Yes.
Okay.
It showed up for me a little later. Yeah, I
Okay.
can see it.
Thank you. So if you look at these bars over here, the 55 to 64 age group for women compared to men. And then, it's also differentiated here. But you see that women in that 55 to 64 age range had a significantly higher incidence of dementia than men in the same age range. And this is a study that looked at vascular factors, and I know that there was just a talk on this, so I'm not going to go into it in too much detail. But in the longitudinal analysis, the baseline hypertension and elevated brachial pressure were significantly associated with increased dementia risk in women. But in men, it was associated with elevated brachial pressure and decreased ABI were significantly associated with dementia risk. So the risk factors operate differently. Individuals with an ApoE4 allele had a significantly higher risk of dementia in both sexes. And I'm going to come to data that actually shows that there's a sex difference there as well. Looking at that graph on the right, this was a paper that had just under 30,000 participants, of which 58% were women, and it blended cohorts, 21 different cohorts across the world into this meta-analysis. And what these survival curves show is that men survived longer without a diagnosis of dementia than women. and that the incidence rates were consistently higher in women than in men across all categories. Um, and so I say this because how do we get there, right? How genetics is one piece. We're going to talk about a whole bunch of different factors, but how do we get to the point where women are facing higher rates of dementia? They're at greater risk, and then some of these risk factors are perpetuated, and that differential risk is perpetuated. That differential risk for women is perpetuated. So the graph on the right, on the left, sorry, the lines illustrate these hazard ratios for dementia in women. In the red, so women are the red squares, red line. Men are the black line, black squares, or black circles rather. And so when you look at people with zero E4, ApoE4 allele copies, or zero ApoE4 alleles, you see that things are not that different, of course. But when you have two copies of that ApoE4 allele, you see that it differentially impacts women. And it was statistically significant. And what that amounted to was that the impact of carrying two ApoE4 alleles on dementia risk was 48% greater in women than compared to men. It had a hazard ratio of 1.48. So it conferred 48% greater risk in women compared to men, which is not trivial by any standard. Drawing your attention to the sort of diagram on the right, this is a couple of years old now at this point, or a few years old at this point, I should say. But this study examined the interaction between sex, ApoE4 status, CSF amyloid beta, and the sort of outcome variable was tau, p-tau, in mid to late life individuals. So these were individuals without dementia in a longitudinal cohort study. And what they did was they compared CSF p-tau between amyloid beta positive. So start with the amyloid beta positive and amyloid beta negative group. And then they looked at sex differences between the groups. So it's a little bit of a tricky one to follow. But the bubbles that are gray, the circles that are gray, show no significant differences. And I want to back up for a second. The bubbles that are orange show an elevation of p-tau. And so when you look at this, the CSF p-tau accumulation in the female carriers of the E4 allele was somewhat independent of the amyloid levels. So even in the amyloid negative cohort, that ApoE4 impact was felt, and the p-tau tended to be higher. The CSF p-tau tended to be higher, even though there was amyloid negativity. And this did not operate the same way for males. And I think that is the key piece here, is that we're looking, because these are markers that we use in our everyday practice as well. But they look different for men and women, and we can't be making the same conclusions. We need to incorporate those sex differences. So coming to cognition, so we talked about the differences in dementia presentations and in dementia incidents for men and women. I want to spend a little bit of time talking about the differences in cognition. So if you look at that graph on the left, this is a little bit of an oversimplification, but males tend to progress in this sort of a gradual downward sort of trend, slope. Whereas females tend to actually stay stable. They tend to not show that impairment, even in the face of preclinical disease. So they could have markers for Alzheimer's disease. They could have those amyloid and tau markers for Alzheimer's disease, but they show some preservation of cognition, and they sort of are a little bit are able to withstand that force until a certain point, and then there's an inflection point. And so the way women progress through the disease of through the Alzheimer's disease is also different. They tend to women tend to have a sort of, there's stability even in the face of those initial biomarkers, and then there's an inflection point and a drop off, whereas men tend to have this more gradual decline. I'm going to point you to the two graphs on the right hand side with the red and green lines. And so, what you're seeing here is it's a word memory learning and recall test. It's an auditory verbal learning and memory recall test. And what you consistently see there in every diagnostic group, so there's the neuropathological change with amyloid positive, MCI, and then dementia. And with every group, women tend to do a little better than men. Now, this is not to say every woman does better than every man, but my point is that at the group level, we are seeing that women tend to have a verbal memory advantage, at least early on in the disease. They tend to have a verbal memory advantage at baseline, and that persists early on into the disease, and then it declines pretty significantly. The reason I bring this up is because if you were to extrapolate what this means, it means that if women are not showing that decline early on, they tend to be diagnosed later. And there's a wealth of literature that I will not be showing here that says that women are diagnosed later than men. And so if we're not picking up on if we're not picking up that someone has Alzheimer's disease biomarkers or is having some subtle decline, they may not even be full-blown MCI yet, we may not even have full-blown MCI yet, but there's a notable decline. We're way better at picking it up in men than we are in women. As a neuropsychologist, I will also tell you it is really important that we use sex stratified normative data here, that we use reference groups that have that separate out women from men. Because if you conflate the two, if you use if you were to look at a bar that was determined based on a combined sample of women and men, we're going to end up overdiagnosing men, which is not good, and underdiagnosing women. And so we really need to be cognizant of these differences as we diagnose, as we treat, as we conduct our research. Okay, so moving on to the next part, we're going to talk about the modifiable risk factors. I'm assuming that most of the audience here is familiar with these, so I won't go into each and every one. These came out in 2024, and the big highlight at AIC, where this was discussed pretty extensively, was 45. They estimate 45% of dementia cases today would have been preventable had we had the information that we do now. If we'd had that information on lifestyle factors, modifiable risk factors, if we knew then, decades ago, what we do now, 45% of dementia cases today would have been preventable. And that's just a staggering statistic. What I also want to point out, Dr. Sabayan mentioned that we need to start with the kids. And that really resonated. We have risk factors that we either have being a risk factor that we sort of target and deal with starting in our early life. So lower education confers greater risk. I will say that lower education is often used as a proxy for cognitive reserve. And so it's been studied in that context too. But lower education in and of itself is a risk factor. Higher education tends to be a little bit more protective against later life decline. And then we've got a host, and I'm going to talk about some of these, not all of these, but we've got a host of modifiable risk factors that come up in midlife. And if you look at these, a lot of them are treatable for men and women. A lot of them are treatable for everyone. Um, a lot of them are treatable, and I should mention this. I say men and women. That is not to discount other genders at all. It is just that a majority of the research, I should say, you know, all nearly all of the research has been done differentiating men and women, which is why I use that terminology. So um, in midlife, there are a host of these factors that really are low hanging fruit for intervention. And then we get to late life, where we can still act, but these risk factors, again, it's not too late to act at all. But I'm trying to emphasize the importance of starting early here. Okay, so if you think about the life course of a woman, um, and I sort of alluded to this a little earlier, um, but there are a variety of exposures of life transitions that women go through that are unique. Um, and this is everything from puberty to pregnancy to menopause. In some cases, it may be, access to healthcare, access to literacy. So in some societies, in some cultures, there is a differential access to education, and that significantly impacts later life dementia risk. Um, we're going to talk about I will ask that this image not be shared. This is an image that our team is, this graphic rather, this graphic is being used in a paper that is in preparation. So I would ask that it not be shared or replicated without that permission. And so we're going to talk about, like I said, some, not all of these risk factors and the ones that are particularly impactful for women. So let's start with the most obvious one. So when we think about, reproductive health, and I know this slide is titled menopause, but I'm also going to talk about menarche. So there's data to show that women who have a longer reproductive span, so earlier menarche, later menopause, tend to have a little bit of a benefit in terms of dementia risk, specifically Alzheimer's risk. That sort of goes along with what the data shows on the effects of estrogen. So we know that estrogen tends to be cognitively protective. There's a wealth of literature showing that estrogen tends to be cognitively protective. FSH, on the other hand, tends to be sort of impacts cognition in an adverse way. And so when you think about menopause, what's essentially happening is the body's losing estrogen. Putting it very simply, I'm not an OB, I'm not a women's health doc, but putting it very simply, estrogen tends to taper off, and there's a loss of estrogen around menopause, and there's an increase in FSH. And so we're losing that neuroprotective factor of estrogen, and we're having an increase in FSH. There's a high degree of prevalence of brain fog and other cognitive concerns. I'm sure we're well aware of that. But there's also, so those are the direct impacts of menopause and the direct symptoms. But there's also, I want to, spend some time talking about the disruption that comes from the indirect effects. So if we think about hot flashes and how those interrupt sleep, for example, we know that low chronic sleep deprivation or chronically low sleep is a risk factor for Alzheimer's. So when we have someone who's going through menopause and is having untreated hot flashes, for example, there can be some really significant impacts on sleep. There can be some really significant impacts on social interactions, and people can often, sort of account for that when they're engaging in social events. It may sort of lead to some hindrance or hesitation. there may also be there's also the piece about the fatigue. So there's not only this brain fog, but there's also fatigue. And so how does that impact their day-to-day functioning, whether it's at work, whether it's socially, whether it's just being able to make it through the day? So we know, for example, that menopause, particularly early menopause, tends to add to the risk that folks have for later life dementia. Um, I will say that there's been much more research in the last few years on HRT for menopause and how it specifically relates to dementia risk. Um, Again, I'm a neuropsychologist. What I know is cognition. And what I can say is that there have been studies that have shown that initiation of HRT in close proximity to menopause, so within the, within say 5 years of menopause, typically that's the benchmark that a lot of studies have used, tends to add a little bit of a protective benefit. Um, the degree to which varies depending on the study, and that the protective benefit diminishes with later starting of HRT, so more distal from menopause. Now, having said that, HRT is a very complex decision and can't be made in a vacuum. Dementia is one thing to consider. There are women with a whole host of other health related factors and complications. And so I think it's a much more complex decision clinically that is far beyond what I can speak to. But I just wanted to put it out there that there's a lot of research being done on the impacts of HRT as they specifically relate to um, dementia risk. Okay. Um, so vascular risk factors, I'm going to cover this very briefly because I know there was a whole talk on it, but just from a women specific standpoint, um, you know, in women, hypertension has been associated with more rapid gray matter atrophy, a higher burden of white matter hyperintensities, and more severe damage to white matter microstructure compared to the impact for men. So these are actual tangible impacts on brain matter, on the neuroanatomy that you can see being differentially higher for women than for men. And then we know that LDL is a big risk factor, um, and that. But here's the other piece: is that it's not just LDL being associated with elevated dementia risk. It's that women are more prone to have an increase in LDL with menopause. And so that compounds that picture. Similarly, with diabetes, men have a greater prevalence of diabetes, but diabetes tends to impact cognition and brain health more than it does in women, more than it does in men. Similarly, with smoking, numerous studies have shown that more men smoke than women. It ranges anywhere from 1 out of 3 men to 1 out of 10 women, which is substantially lower rates of smoking in women, which is, excellent for women, not so much for the wet men. And we know that smoking is, dementia is one risk factor, but smoking causes a whole host of other health-related issues. But when you do a little bit of a deeper dive into the smoking trajectories of men and women, women face greater dependence on that tobacco. They also have greater difficulty quitting smoking. So they tend to have, and they have, similar to what we saw with diabetes, there's a greater impact on cerebrovascular disease risk. And so, yes, less women smoke, but those that do have a harder time quitting. They have greater dependence, and the risk related to dementia is significantly higher. The other thing I want to spend a little bit of time talking about is physical activity. And this is, again, where that sex and gender piece comes into play. So more recent statistics show that um, in general, on average, not one to one, just on average, group comparisons, boys tend to be more active than girls, with more boys meeting activity guidelines, country specific activity guidelines, than women, than girls, rather. Um, the other important thing is that we have known about the benefits of physical activity for a long time now. Women continue to be less active than men by about 5%. And this is a statistic that has not changed since 2000. So in the last 26 years, despite all we know about physical activity, we still tend to, women tend to not be as physically active as men. And this, when you think about it and this is just a general statistic, right? This isn't specific to dementia risk. But when you think about how exercise impacts dementia risk, um, women tend to derive greater benefits. So all those red bars there are showing women, and the blue bars are showing men. So women derive greater benefit. Their risk is reduced to a greater extent by physical exercise, by physical activity than men. So physical activity is more impactful on that risk reduction for women, and yet we do it less. Yet that statistic has not changed since 2000. And so I you know, I think that's important from a risk reduction standpoint, from a prevention standpoint, where we're moving the needle, not enough, particularly when women tend to benefit more from this kind of intervention or change. Okay, so moving on to the impact of stress. And I'm going to forewarn you, there are some conflicting findings. So the panel on the left, which is the Paolillo study from 2023, it was taken from there. So this study examined sex differences in the relationship between perceived stress, cognitive functioning, specifically here on executive functioning, memory, and processing speed. And then it also, over time, in cognitively normal older adults. And this was within an observational cohort of aging. And so what they did was they used a self-report stress, perceived stress scale. And if you look at the lines, so the left panels are men, the right panels are women, the top is executive functioning, memory, second is memory, and panel C is processing speed. The top line in each one, the black line, is low stress, low perceived stress. Higher scores indicate more stress, so low perceived stress. The middle line is moderate stress, and then the light blue line is high stress. And what they found was that in general, there was an impact of higher stress on cognitive performance. That's pretty intuitive. So in every single panel, you'll see that light blue line being right at the bottom and a steeper decline, suggesting that there was a consistent impact of stress on cognitive performance. Higher stress groups tended to perform worse than lower stress groups. However, when you focus on that top panel there, you see the higher average stress score was related to steeper executive declines in men, but not in women. And so men here, in this paper, are more vulnerable to the impacts of stress, whereas women tended to have that consistent cognitive performance despite the stress, despite the perceived stress. And so this tended to show as sort of an opposite story to what we've been talking about now in terms of greater vulnerability in men as compared to women. Now you look at the graphs on the right, and this was a sample of cognitively unimpaired individuals, 270 plus individuals, and the sex-specific modification effects were noted where cortisol, and this was again by cortisol. So cortisol exhibited a stronger association with amyloid beta load and frontal glucose metabolism, which was more pronounced postmenopause. Whereas in men, cortisol exhibited stronger associations with gray matter volume and posterior cingulate and ATP measures. My point here is not the nitty gritty of what they showed. My point here is that men and women look different when we're looking at cortisol, when we're looking at the impact of cortisol, when we're looking at the impact of cortisol on cognition, when we're looking at the impact of perceived stress on cognition. Depression is another significant risk factor, which is, I mean, we all advocate for treating that depression as early as possible. The data seems to suggest that depression that where there's an onset in midlife or later life tends to confer the most risk in terms of developing dementia. So if you look at someone who has chronic depression from, let's say, adolescence, the data would suggest that they are the depression alone would confer lower risk there than it would for someone who had new onset depression in mid to later life. And so I want to just point out in this paper, again, I'm not getting into the nitty gritty of it. It's more about the overall theme where women look different from men. So in this paper, the authors hypothesized that the stress response abnormalities in major depressive disorder, and this was folks within a major depressive episode, and it might be impacted by sex and stress exposure time. So what they did was they had folks take a stress task while they were undergoing an fMRI. And so then they looked at activation levels in the different limbic areas. And so what they found was the female MDD group, the female group with major depression, had significantly less deactivation. So deactivation here is good, but they had significantly less deactivation relative to the healthy control group in the amygdala, in the hippocampus, and in the nucleus accumbens. And so when you look at these patterns, you look at males in blue, females in red, and you see that throughout, you see that the healthy control patterns are for the males and females, they're different, but they kind of stay consistent throughout the different brain regions. But then you look at the major depressive disorder group, and you see how males and females, how men and women did here. They're different. They look different. They operate differently. And this is just deactivation rates within a stress task. We're not even looking at the effects of chronic depression. We're looking at a single depressive episode. And so when you extrapolate that, I mean, the odds are that the impact of depression, when you think about it over time, is going to be very, very significant. The other big one is sleep. So 8 hours is the optimal sort of threshold to strive for. Anything below 6 hours of nightly sleep and far exceeding 8 hours with daytime naps and such has been shown to be more predictive of progression to dementia. There are sleep patterns that change due to aging, and that's somewhat normal. But it's when you start seeing these big shifts to either much less than 6 hours or significantly higher than 8 hours that you start seeing concerns with sort of a dementia risk. We also know that excessive and inefficient excessive sleep or lower amounts of sleep have impacts on things like metabolic profiles, increases in insulin, particularly with that oversleeping piece. And so those also have indirect effects. Sleep apnea is a huge one. Again, I'm not a sleep doc, but what I know is cognition. And I put this graph, sorry, this sort of flow chart, if you will, that came out in 2024. And it shows the different ways in which sleep apnea may impact cognition and eventual dementia diagnosis. And so it's not just the intermittent hypoxia. It's not just, and I say just very loosely, it's not just the sleep fragmentation. It's not just how our body breathes at night. It's so much more. It has direct impacts on the accumulation of amyloid plaques. It has direct impacts on the way in which our lymphatic system and our microglia clear amyloid. And it has direct impacts on tau accumulation, tau phosphorylation. And so sleep apnea is one of those things where if someone has been diagnosed with sleep apnea, it's imperative that it's treated. With regard to women, specifically, women are less likely to report snoring. How many times have we seen, I see this all the time in clinic where I'll ask someone, well, do you snore? And, oh gosh, no. And a woman will say, oh gosh, no. And the spouse will look at them and go, about that, and kind of snore a little bit. And there's been a cultural impact of how we report snoring, where it's more acceptable for men to report snoring than women. And while women may have lower apneic indexes, lower AHI, they tend to have greater cognitive impacts from untreated sleep apnea. There's also the impacts from insomnia and restless leg syndrome, where, and again, physical activity can help with some of this. And I just looked at the time. I do want to spend a little bit of time talking about protective factors. So we talked about low education being a risk, but educational attainment broadly is protective. So encouraging girls and women to keep learning, whether that's formal education. I fully acknowledge that the sociocultural factors, social determinants of health may or definitely impact one's education and how far we can go. But even if it's not formal education, learning, continuous learning, learning a new language, learning a new musical instrument is critical. Keeping those wheels nicely greased and moving is key. And one of the other ways to help with that is social engagement. I already alluded to the longer reproductive span a little earlier. There's not much that one can do here in terms of changing that. But I just wanted to list these as some of the more impactful protective factors specifically for women. You know, one thing that I did not, because it wasn't really central to this talk, but I know that we've been talking about anti-amyloid therapies here. And one of the the different drugs, lecanemab, donanemab, et cetera, if you go and you do a deeper dive into the data behind those and how they look for men and women, men tend to derive a little bit more longer term benefit from lecanemab than women, whereas that sex difference tends to be a little less or a little more attenuated in the case of donanemab. But my point here is as much as we can do to maximize protective factors for the individual in front of us is what we need to be focused on. So in terms of recommendations, if you take nothing else away from this talk, I think if you bring an awareness of sex differences to clinical practice and research, we may not have all the answers. We may not know exactly how, exactly what the impact of a certain cognitive test or a certain drug is, or a certain intervention is going to be for this specific individual. But bringing that awareness of men and women operate differently, we might see some differences in the impacts and the outcomes is critical. For the risk factors, again, with the Livingston risk factors, we want to treat that depression whether it's using pharmacological means, whether it's using CBT. CBT tends to be highly evidence-based and supported, particularly for mid and later life depression. I would rely on those CBTI for sleep dysfunction. Cognitive behavioral therapies is what I'm referring to, but cognitive behavioral therapies, particularly for insomnia, for example, treating that sleep apnea to limit the impact of it on cognitive decline or increase the risk of cognitive decline. I'm not going to pretend to be able to do justice to the vascular risks. I know that there was a whole talk on that. We talked about menopause and the impact on cognition, the impact on dementia risk. Too often, women, menopause is discounted, but acknowledging that it does have a real impact, even if it's an impact that most women go through and it's sort of a high frequency impact, it is still an impact on cognition. And so, again, HRT is a very, very complex consideration to make, and I would defer to folks to have those discussions with the appropriate healthcare provider for that. And then just encouraging that physical activity with the knowledge that it has so much more impact for women, and that women are the ones who don't do it as much. And with that, I will stop.